response, it will give you a effect. Is that clear? Yes?
Yes, sir.
Yeah. Again, these are dynamic in nature and these are flexible. So whatever interaction happens, it can dissociate also. Like I said, most of the times these are reversible and they can separate also, or they can remain bound. Yes. However, these are usually, like I said, flexible. So there are exceptions, but yes, most of the times the drug will get dissociated from it comes out like a key from the lock. Yes. Okay. Is this point clear to everyone?
Yes, sir.
Okay. So, like we were discussing earlier, at times what happens is a drug, when you take any medicine in the body, it can be absorbed at the site of action, and then it will go and so it will be so wherever we are administering, it will be absorbed, and then it can go into your systemic circulation. Some of the drug can go and bind to local sites where it will deposit itself. Okay. So again, the drug, when it is available in the bloodstream, is transformed or biotransformed, as we say. Okay, so it is metabolized after it is there in the bloodstream, and finally it is excreted from the body. Yes. So the ones which are in the circulation can go and bind to the particular site of action or the receptors. Yes. And at times they can also be present in the tissue reservoirs. Yes. So the drug which is bound in the specific adipose tissues and various other places, it can stay in the body for a longer duration by binding. Yes. Okay. Is this point clear?
Yes, sir.
Yeah. And we have also last time, I think, touched upon that usually they advise not to lose weight suddenly for patients. Yes. Why is that? Is because of this drug which is present in these reservoirs or which is bound will, when you lose weight, what happens is all this drug will come back into the bloodstream in the systemic circulation. Yes. Okay. So then it can give flashback effect. Now, what is a flashback effect? It is like how you are taking a drug at that time, what effect you would have experienced. That effect will come on its own, even without eating a medicine. Yes, because the drug which has been deposited or maybe bound in the tissues gets free and comes in the circulation. Yes, is this point clear? Yeah.
Yes, sir.
Again, the advent of molecular pharmacology is considered as the basic for how the drugs are known to act on the various biological systems. So this idea that the drug was acting upon specific sites or what we now call as a receptor, at that time it was first identified as a receptive substance. Okay, so it was started by John Newport Lange, who was at Cambridge. Yes, he was the one who had first, brought out this concept that the drug will go and bind to specific sites. Okay, however, the word receptor was given by Paul Ehrlich. Okay, so the receptor concept now forms the basis for the development of all the new drugs. Yes, isn't it? So why? Because now what we try to do is we try to look for specific action of a drug, that it should go and bind to a particular receptor, yes, within the body, isn't it? Yes. So what is targeted drug therapy? Anyone knows about it? What is targeted drug therapy? Yes.
Like, sir, for example, chemotherapy.
Chemotherapy is not a targeted drug therapy. Usually now the newer medicines in oncology that we are getting, which are, specifically biologic products, so they are the targeted therapies where we are targeting a specific cell, cancer cell only. Remember last time we have discussed that, this medicine in chemotherapy, whatever we take, there are various common observed side effects. Yes. So like you have hair fall, and also the patient who is undergoing chemotherapy can
Weight loss.
experience, yes,
Yeah.
also vomiting, nausea, indigestion. Yes, because the fastest growing cells in our body are again the mucous membrane. Yes, because it protects all your elementary canal. Yes or no? And because these drugs, chemotherapy drugs, like various, toxic compounds. So why we call them as chemotherapy is because these kill the cells. Yes, and they don't differentiate between the cancerous cells and the fast growing normal cells. So that is why patients with cancer, when they are treated, also have low hemoglobin, or even the white blood cells, the neutrophils. Yes, these are all affected by the chemotherapy. Yes, because they are fast growing cells in our body. Is that clear? Yes.
Yes, sir.
Okay. So again, the concept of targeted therapy was brought in with the idea of first establishing that there is a receptor in these cells where the drug can go and bind specifically. Yes. So once that has been identified, now the all these biological monoclonal antibodies are being used, where these will go and bind only to a specific site on the cancerous cells, and that is why there are lesser side effects, as we say, or adverse reactions. Okay, is this point clear?
Yes, sir.
Okay. So the receptor concept, which forms the key note of our development for molecular pharmacology, was established further by Alfred Joseph Clarke. He was a professor of pharmacology at King's College London. So he had further developed that, okay, this is, the concept of molecular pharmacology, and how the drug can go and act at the cell level. Okay. Is this point clear to everyone?
Yes, sir.
So receptor, like I said, is the key element, which so in addition to its usefulness for explaining how the receptor can act in a particular cell, it's also used, or practically it has consequences for, like I said, development of new drugs, and also arriving at what medicine to be given, or what therapeutic decision has to be taken in our clinical practice. Yes. So I'm sure that most of you would know, okay, if there is a problem in respiratory tract. Yes. Yes. So, what is the most commonly given medication for difficulty in breathing? Salbutamol, yes. Okay. So these again, salbutamol or many other drugs of the same class are used for relaxing or the passage or the bronchi and the bronchioles, so that the patient can easily breathe. So it is usually given in COPD patients or even in normal asthmatic patients. Yes. And we now know, because of the molecular pharmacology, that there is a receptor, which are the beta receptors. Yes. Okay. Where these, which are present inside the respiratory tract. And if we, give a particular drug, they will act on those receptors and will relax the muscles lining the respiratory tract. Yes. Isn't it?
Yes, sir.
Okay. So it is based on our understanding of, like I said, the molecular pharmacology. Yes. Okay. So we call them also as the bronchodilators. Yes. Yes or no?
Yes, sir. Yes, sir.
Okay. So it's used again in, like I said, COPD and cough, or even so many of the cough preparations you will see, syrups and all, will also have salbutamol. Yes. Yes or no?
Yes, sir.
Yeah. And these are basically, like I said, the beta 2 receptors which are present on the respiratory tract. Yes. So, based on the knowledge that we have now, we can also develop drugs to see specifically if it is having action only on the beta 2 receptors. Yes. Okay. And so, what is the drug doing if we are taking salbutamol? What is it doing? What is it trying to do? So, it is trying to mimic, it is trying to copy the normal, naturally occurring hormones. Yes. Isn't it?
Yes, sir.
Yeah. So, hormones like epinephrine and norepinephrine. Yes. So, they are going and binding to the beta 2 receptors. Yes. Okay.
Yes, sir.
And that in turn relaxes the smooth muscles of the airway to relieve these symptoms like chest tightness or shortness of breath or cough or wheezing. Yes. Okay. So these are released once we take a drug that goes and binds. So what we call that binding drug, there is another term which is used called as agonists. Yes.
Yes, sir. Beta 2 agonist.
Yeah. So beta 2 agonists. Again, there can be two types within that also. There can be some short acting and there can be some long acting, depending upon whether we want a quick action in asthma or do we want a longer duration action. Yes or no? Yes.
Yes, sir.
So we call them as the SABA or the short acting beta 2 agonists. Yes. Okay. Again, there can be long acting ones also, which are used to control the chronic symptoms or prevent asthmatic attacks. Yes. And decrease all the, asthmatic symptoms. Is that clear? Yes.
Yes, sir.
Okay. So again, like you said, salbutamol, yes. So similarly, we have different drugs of the same class, the long-acting ones, which are like salmeterol and formoterol, different molecules which are similar of the same drug class. Yes. So they are the long-acting beta-2 agonists. Is that clear? Yes.
Yes, sir.
Again, many a times you would see that not just using these beta agonists or the beta-2 agonists, they are also relying at times on different steroidal or the corticosteroids. Yes, the inhaled corticosteroids. Yes or no?
Yes, sir.
Yeah. So we have different corticosteroids available, like you have fluticasone or you have budesonide. Yes. Okay. And these are available in different combinations with the beta-2 blockers or with the beta-2 agonists. Yes. Is that clear? So if you go and buy any medicine in the, for respiratory issue, all the inhalers, like you have Symbicort. Okay. So Symbicort, or there are different brand names, Briana, Symbicort, all these have budesonide and formoterol combination. And then there is another Advair is a very commonly sold.
Foracort. It's Foracort.
Yeah. So fluticasone and salmeterol combined Advair. And different combinations are now available. If you buy, even now in India, we have Cipla selling a lot of combinations. So there is formoterol fluticasone, FNF. Yes. Or there is cyclesonide formoterol, CNF. So different combinations are now available. Again, where they are combining these corticosteroids with the long-acting beta-2 agonists. Okay. Yes. Is this point clear? So the beta-2 receptors are found in our lungs, like I said, or even in the digestive system or uterus also. Some are also present in the blood vessels. Okay. So again, the chain of reaction starts once these beta-2 agonists go and attach to the receptors in the muscles of our airway. So what it causes relaxation, and it causes lesser bronchoconstriction. Yes. Okay. Is that clear? Yes.
Yes, sir.
And you will be surprised to actually, know that many, Chinese medications and many Ayurvedic medications relied on these beta-2 agonists from natural plant sources. So in the medicines, thousands of years ago, they had discovered many of these drugs. Yes, which will improve breathing. Yes or no? Yeah. So what they had done was, these plants had a natural source of epinephrine, which is similar to, again, the hormone which is found in our body. So that was a plant epinephrine. Right? Is that clear?
Yes, sir.
Okay. But then again, with these beta-2 agonists, there can be some other things, like it can increase the heart rate, it can cause headache, it can cause dizziness, anxiety. Yes. So all these things can be the other effects, or there can be very serious side effects also. So it can result in rashes or hives. Yes, allergic reactions, or even can result in swelling of the mouth or various areas, face, lips. Okay, you can have chest pain also. It all depends. If somebody has a reaction, it can be a very severe reaction also. Clear? Is that clear?
Yes, sir.
And actually, in 2006, FDA had given these long-acting beta agonists a black box warning. So, what is a black box warning?